Good afternoon, and welcome to Post-Traumatic Trigeminal Neuropathic Pain, Nerve Injury Following Dental Treatment, featuring Dr. John Zuniga. I'm Melissa Bombick, CEO of the Facial Pain Association. Welcome, Dr. Zuniga. We're really glad you're here with us today. Before we begin, I want to go over a few housekeeping items. On your screen, you should see an option for both Q&A and chat. We encourage you to connect with other attendees using the chat feature. Please reserve the Q&A for your questions, and we'll get to as many as we can following the presentation. I plan to monitor both, but using the designated option will hopefully allow us to get to more of your questions. Although our presenters today may be doctors, they are not serving as your doctor during the Q&A and are unable to answer questions about your specific health situation. We request that you keep your questions general in nature, and we will do our best to select questions that will benefit most people living with facial pain. Let me quickly introduce our speaker, and then we'll get started. Dr. Zuniga is the professor in the Department of Surgery at UT Southwestern Medical Center and holder of the Robert V. Walker DDS Chair in Oral and Maxillofacial Surgery. He specializes in oral and maxillofacial surgery, specifically temporomandibular disorders and neurosensory disorders. As an experienced trigeminal nerve microsurgeon, Dr. Zuniga has performed more than 300 nerve repairs. He also has a clinical interest in benign pathology, dentovelar surgery, and trauma of the oral and maxillofacial region. Okay, Dr. Zuniga, I'm going to turn it over to you. Please go ahead.
Thank you very much, Ms. Bombick, and I appreciate the honor to be a participant in this week's program. And I appreciate what the Facial Pain Association represents. I recall the Trigeminal Neuralgia Association would have many on-site presentations, and I sat in on several of those, and I was always impressed with the attendance and the attentiveness and the discussion. So I'm honored now to be on a participant today. I chose the term post-traumatic trigeminal neuropathic pain for several reasons. One, certainly within my area of interest, and that is the trigeminal system. I do want to make the point right up front that this is not trigeminal neuralgia. And so my task today is to discuss and define what this problem is. So, but first, a few things. One, my disclosures. I am a consultant for Axogen Incorporated. I use their products. And I'm also on the board of directors for a new 501(c) nonprofit foundation called the Global Nerve Foundation, which the mission is to enhance the lives of individuals who have peripheral nerve injuries anywhere in the body. Neither of these organizations had any input or direction or support of what I'm going to speak today. So why don't we just go right into it? And everyone on this call probably understand or has an understanding of what we're faced with, and that is chronic pain. And that's being defined as pain lasting more than a few days that acute pain would be defined as, and it being principally more than a month or so of continued pain. If you look at the four most common types of chronic pain that the NIH published, you can see on this slide that low back pain is certainly the most prevalent, then migraine pain, then neck pain, and then we have facial pain as representing 4%. Now, I'm going to talk about that facial pain component where this particular problem resides. And if you look at facial pain, and especially in my area, more than 85% of patients who have chronic oral facial pain is due to odontogenic or tooth-related. That's toothache, a pulpitis, an abscess. Again, 85% of patients have chronic dental pain as a source of their facial pain. Then you drop down to 10 to 12% of temporomandibular joint disorders, which are going to include lateral facial pain associated with abnormal jaw movement and often with joint sounds. Then drops down even again to 4% of patients have what's called burning mouth syndrome, of which 10% of the postmenopausal female population have burning mouth syndrome. And then drops down again to 0.03% of atypical facial pain or odontalgia. And then the topic I'm going to speak today drops to 0.02%. And even below that is trigeminal neuralgia at 0.005%. So there are multiple different sources of facial pain, from almost 85% or more being odontogenic to 0, 5 in 100,000 people developing trigeminal neuralgia. And I'm going to make the point that if you make the wrong diagnosis for your facial pain source, you're going to provide the wrong prognosis and the wrong treatment. And my point is this: if you have a toothache, it needs to get treated for a toothache problem, not a trigeminal neuralgia. We've all know cases in where the wrong diagnosis was made and the wrong treatment was provided without relief or worsening of the pain condition. And that's an important point I would like to make. So I'm going to specifically talk about post-traumatic trigeminal neuropathic pain. I'm going to term it in my slides as PTTNP. Now, what I want to do this next 30, 40 minutes, I'm first going to define what PTTNP is, then what are the treatments for PTTNP, and then what are the treatment outcomes for PTTNP. And that's my goal here. Let's define it. Neuropathic pain is best defined by its symptomatology. And I'm going to use terms hyperalgesia, allodynia, and hyperpathia. Radiating pain, burning, or sharp pain, and is often associated with some degree of numbness and tingling. Now, the IASP initially defined the cause in the first sentence that's in black: pain initiated or caused by a primary lesion or dysfunction of the nervous system. Since the mid-2000s, the definition has been redefined, and this is important, and that's in blue. It is pain arising as a direct consequence of a lesion or disease affecting the somatosensory system. No longer is it considered a dysfunction. It's a lesion, and that's important. The etiologies of the neuropathic pain anywhere in the body, we're going to specifically talk about trigeminal, is mechanical, trauma, chemical, medications such as even local anesthetic or steroids, infection. Infection can cause inflammation around nerves, or metabolic causes, i.e. diabetes. So these are actually primary lesions that cause a direct consequence that results in pain affecting the somatosensory system. The motor system is not included. This is a somatosensory system, i.e. feeling, touch, tactile, temperature, pain. That's the definition of neuropathic pain. Now we can further define what those terms of hyperalgesia, allodynia, and hyperpathia are in this slide. Neuropathic pain is severe out of proportion to the stimulus. It can be spontaneous, it can be continuous or lingering, but it is generally stimulus-induced. And those were the terms hyperalgesia, allodynia, and hyperpathia include. Now, if you look at this little section of your slide right here, this is pain sensation, 0 to 100, 100 worst ever. And this is the intensity of the stimulus. In other words, the stimulus is increasing. Now, if you look at the normal curve here, this is the normal. There's two components of this pain. Innocuous stimulus, in other words, stimulus that generally does not cause pain, is innocuous stimulus. Nociceptive stimulus is a stimulus intensity that begins to cause pain. And any stimulus, for instance, pressure, if you put light pressure anywhere in the body, most people will say, I can feel it, but it's not hurting. But if you put more pressure over the same site, or you increase that intensity, it starts to become painful. Now it reaches the nociceptive stimulus. This is measurable. Now, what makes hyperalgesia and allodynia occur are these definitions. Allodynia occurs when the normally innocuous stimulus is painful. In other words, light touch that shouldn't cause pain causes pain, or slight pressure that shouldn't cause pain normally causes pain. That's allodynia. Now, if you increase your stimulus intensity, you should create pain. But if you're creating pain in the normally innocuous stimulus zone, this is called hyperalgesia. In other words, as you increase the stimulus, under normal, the pain increases. Same with neuropathic pain, but at lower thresholds and lower tolerances. These are measurable values. Hyperpathia is repetitive stimulus that is in this zone that causes characteristics of pain, such as summation, a pain stimulus of the same intensity starts to increasing the pain without increasing the stimulus. That's a very abnormal type of pain response. That's called hyperpathia. And often, in a normal pain, if you stop the stimulus, the pain level drops. But in hyperpathia, you stop the stimulus, the pain continues. That's called overshoot. These are measurable stimulus modalities in the proper diagnosis of neuropathic pain. Keep that in mind. But it also can be spontaneous, and some people use the word sympathetic, autonomic, or central, dolorosa. And what that means is it could involve other parts of the nervous system, including the central nervous system. The dolorosa is a term that would describe complete removal of the peripheral nerve, yet there's pain at that site. Phantom limb pain. Same thing can occur in the trigeminal system. Sympathetic may be vascular type of source pain, and it may be a source or contribute to the burning component of pain. But where the problem exists in our understanding of trigeminal neuralgia, we all know that there are triggers, and that tactile sensation creates an electric shock. Yes, that's classic trigeminal neuralgia, lasting seconds and then abating, whereas allodynia, hyperpathia, hyperalgesia are similar, could be electric, could be burning, types of pain that are measurable and included in these terminologies. Now, given that, there is a process in where we make the proper diagnosis of post-traumatic trigeminal neuropathic pain is best defined in this publication in Pain. And here is the pathway I recommend following. The leading complaint is pain. The history is a history of relevant neurologic lesion or disease and or pain distribution in the neuroanatomically is plausible. In other words, there's pain, and it follows a lesion, be it chemical, metabolic, traumatic, infectious, and the pain distribution is in the correct distribution of the nerve. If a pain is located in the right chin or lip area, and the lesion was on the left side, that is not going to fit the diagnosis of post-traumatic trigeminal neuropathy. So a pain on the left side with the trauma on the left side and the correct distribution of the nerve, the end terminals, would be a possibility of, you have to consider post-traumatic neuropathic pain. Most patients with trigeminal neuralgia don't have a history of trauma. They can have a history of trauma. A tooth extraction, a root canal, or something along that line could be a source of trauma. Yes, but is it in the correct distribution? An upper tooth root canal causing lower chin pain is not consistent with post-traumatic trigeminal neuropathy. So if the pain is in the correct distribution of the nerve following some form of lesion, it's possibly neuropathic pain. And that's where the examination occurs. And if the pain is associated with the sensory signs in the same neuroanatomical distribution, in other words, an injury, pain, then you perform neurosensory tests. And if there is an alteration in the somatosensory function, in other words, some degree, not complete, some degree of sensory deficit, in other words, a numbness. Now that means different things to different people, so you can measure that. And so in the process, the first thing I would do is once a patient identifies the pain in the distribution of the nerve, I test within that distribution if there's a sensory disorder. If there's no sensory disorder, such as in trigeminal neuralgia or atypical facial pain or TMJ, then it is it would be possibly post-traumatic trigeminal neuropathy. Once you have that confirmed, that there's distribution, there's a problem, a sensory disorder, then I perform confirmatory tests. And that is the diagnostic test I just talked about. And I identify the presence or absence of allodynia, hyperpathia, hyperalgesia, burning pain in that distribution. With those three combinations, you should correctly define this condition as neuropathic pain. So in a patient, for instance, that have trigeminal neuralgia, their pain distribution is often not associated with a sensory deficit. It's sometimes not associated with only a small area of the normal distribution of that nerve and doesn't show hyperpathia or hyperalgesia, but there's often tactile allodynia that I do appreciate that. But without the appropriate steps to define this, if you make a diagnosis of trigeminal neuralgia for this condition, the treatment and the prognosis is totally different, and vice versa. If you have a post-traumatic trigeminal neuropathic problem and you treat it like trigeminal neuralgia, the failure rate is going to be high, and interventions, including surgical, can actually make the condition worse. So the diagnosis is very important. Now, who are these patients? And this is a study back in 1990, a long time ago, but it's still relevant. And we talked about dental conditions. So those dental conditions that are more commonly associated with the development of post-traumatic trigeminal neuropathy were published in 1990 by John Gregg. Odontectomy being number one, extraction of wisdom teeth being the number one of that group. But simple extractions can also, that are surgical and result in damage to the regional nerves, not root canal. We'll talk about that in a second, but not the actual act of the root canal unless it's performed inappropriately and where material is sequestered beyond the normal bone distribution. But extraction of teeth, especially third molar surgery, is the most common cause of PTTNP. Preprosthetic or implant placement can impinge and actually mechanically damage the nerve. The most common nerve being damaged, the inferior alveolar or the nerve to the lower jaw. Rare is it's lingual. It can include the maxillary, but extremely rare. Orthognathic is a form of treating developmental disorders of the face. When our lower jaw is too far forward, it's brought back, or lower jaw is too far back and brought forward. Upper jaw is too lengthy. You can intentionally fracture the mandible or the maxilla in a pre-planned way and move the structures. And in so, the nerves in those structures can be injured. So that is another form of injury for PTNP. And then endodontic. Now, how does an endodontic condition, root canal therapy, result in nerve damage? The materials that are used to obfuscate the pulp are materials that are destroy or fixate tissues. When that material is extruded beyond the root apice of the bottom of the root, it can enter into these nerves. And that's a form of a chemical injury, not necessarily mechanical. These are probably mechanical. This is more of a chemical. And there is another fifth line here you'll see on the next slide, and that is the local anesthetic injections, and we'll talk about that. In terms of frequency, 81% of these patients who had PTNP, the pain was constant. But 20%, it was not present all the time, but in stimulus-induced pain, allodynia, hyperpathia. The pain intensity was very similar across the patient population. On a 0 to 10 scale, these patients all report in the 6 to 10 distribution. So it's very distressing type of pain. If you look at the stimulus components, 85% were that hyperpathic pain. In other words, it was that pain that you normally repetitively tap the area to a normally innocuous, but it's painful, that has overshoot summation, was the most common, then hyperalgesia and allodynia, and then this hot burning pain, and then the anesthesia dolorosa type of a pain condition. Now, this complex slide, and I apologize for this, but this was a well-done study by my colleagues in Belgium and in the UK area. And let me take you through this. It's a very important slide. This is the normal frequency of neurosensory distributions on all three slides. This is duration, up to 100 weeks, a couple of years on all these slides. And the first one shows initiating event. We talked briefly about that. Third molar surgery, tooth extraction, endodontic implant, but they also included local anesthetic. And if you look at the different, these 5 variables across duration and recovery, local anesthetic injections had the highest success rate by doing nothing. In other words, local anesthetic injuries, in our literature, about 1 in 40,000 local anesthetic injections can cause a sensory change that creates numbness of the lip or chin or tongue, and sometimes the neuropathic pain. But 98% recover spontaneously. Third molar surgery is in this pink, and then tooth extraction, endodontic, and dental implant had the higher percentage of creating chronic long duration problems. If you look at the type of injured nerve, you have the inferior, which I talked about, that's a nerve to the lip and chin. The lingual nerve, the lingual nerve here in pink, that's the nerve to the tongue. And then the maxillary nerve, that's a nerve to the upper face. And there was a significant difference, and that is the poorest prognosis if the nerve is injured, creating any of these kind of conditions. The upper nerve had the lowest chance for spontaneous recovery. The lingual having the best, the inferior midway. Now, if you look at the sensory profile, this is very important. These are 9 different clusters, they call it. But if you look at the cluster of pain conditions that were chronic and persistent and did not spontaneously resolve, they all fell into the when they were these clusters associated with pain. Whereas without pain, there is spontaneous recovery in most of these conditions. So the presence of neuropathic pain, in addition to injury, by any source at any location has overall a poor prognosis for spontaneous recovery. One of the questions that I'm still trying to determine is will post-traumatic trigeminal neuropathic pain, which we define, will it spontaneously resolve? Apparently, the answer is no, unfortunately. Will it get worse? That's another good question. Untreated, will it get worse? None of my colleagues nor I have that answer. In my experience, no, but I use that tentatively. So if pain is present and it is worsening, I generally would ask my patient to be reevaluated for the potential problem. Is there a way you can make it worse? Yes. If the pain source is due to injury of the nerve, a second injury often is associated with making it worse. And again, if you don't have the right diagnosis and you treat it like with a non or invasive modality, you can actually make the pain condition worse. Now, what are the treatments for PTTNP? This complex slide is probably the algorithm it's generally accepted. And this is in Pain Medicine in 2019. And there are 5 lines of therapy. The first 2 lines of therapy, oh, by the way, these are based on evidence-based studies, RCTs, observational studies, cohort, randomized, prospective, or retrospective studies. And to make this kind of easy to follow, there are 5 lines of therapy. Each are associated with the weeks of therapy before moving on to the next level, as suggested, from 1 to 5. I'll go through this quickly. But if you look over here on this slide, this is multidisciplinary pain management, rehabilitation, psychological, sleep hygiene, exercise, other. And we encourage, or this article encourages, and I too encourage, patients to consider behavioral modification or behavioral multidisciplinary team management at any throughout the whole lines of therapy, because chronic pain creates alterations of behavior. You can enter at any time, but a recommendation is that any phase of the lines of the treatment behavioral therapy should be considered. The first line of therapy are medications. Those are the tricyclic antidepressants, we'll define those. The SNRIs are the sympathetic also serotonin reuptake inhibitors, and then the anticonvulsants, such as the tegratols, etc., and then topicals. The second line are tramadol or combinations of this. Now, let me define that. And this, again, sorry for the complexity, but briefly, the first 2 drugs that are most effective, in my opinion, in the first line are the GABAnoids, and that's gabapentin and Lyrica, or pregabalin, or Neurontin, and the tricyclic antidepressants and the serotonin norepinephrine uptake inhibitors, Cymbalta, Effexor, tricyclic antidepressants, Elavil, Pamelor. Then we talked about topicals, lidocaine topicals, if on extremities. Yes, you can use oral lidocaine, but and then there's capsaicin. Capsaicin often used on extremities. Can you use it orally? The answer is yes. There is a formulation of providing capsaicin in a candy formulation. It can be very effective and it's non-harming. But and then the combination therapy, which is line 2, when you start combining the GABAnoids and the TCAs, or the GABAnoids and the SNRIs, and then tramadol being in the second line. You do have to be careful when you're using tramadol with the TCAs and SNRIs for adverse events. Now, the first line of therapy, again, given for 4 to 6 weeks. If ineffective, then second-line therapy. If ineffective, then the third-line therapy. And the third line of therapy are the surgical interventions, interventional therapies. And then the fourth line, if it fails, then the fourth line of therapy are the neuromodulator therapies. And if that fails, the last line or last ditch are low-dose opioid therapies in chronic pain management. That's the current accepted algorithm for the management of neuropathic pain, including PTTNP in my practice. Well, let me briefly talk about two neuromodulators. Botox has been around and utilized for not just cosmetics or TMD, but it's been recommended for treatment of neuralgias or PTTNP. And in the laboratory, it seems to decrease the neurotransmitters that may be associated with both of these conditions. And we know that it can retrogradely transmission to the ganglion cells. In my experience, it is helpful in maybe half of my patients. And I think the reason why it works is this. It does what it does, and that it paralyzes the muscle bundles and preventing movement. And movement is a known trigger to both of these conditions. So it can work, but it is not predictably better than chance to work. And I reserve the use for Botox in the face and mouth especially, because it's going to do what it does. If injected into the lower lip or chin area, that lower lip or chin on that side, the muscle will not move. So it creates a cosmetic problem because the lip will lift up, or if it's an upper lip, it'll fall down. You have difficulty retaining fluids because of unable to make a lip seal because of loss of muscular lip closure. So you have a cosmetic problem and a functional problem. And if it doesn't help the pain, I've actually made that patient worse because now they can't move, they look funny, and they still have the pain. The good news is it only lasts 3 to 6 months, and that's also the bad news. So in my practice, Botox has not played a strong, predictable role. Other neuromodulatory modalities you'll read about and see about, and I just included this one, not on purpose. I really don't have much experience with this group. And this is these electric cell signaling energy waves. So pulses, nerve pulses, we know nerve, peripheral, and or central respond to a variety of stimulus. And so pulse therapy is one. Low-level laser, which is basically heat therapy, ultrasound, TENS, are also neuromodulatory modalities. I have our literature and my experience is that TENS, low-level laser, ultrasound have not been effective for PTTNP. And one of the other challenges is that the nerve source, nerve sites are not always located outside and on the face, can be intraoral, and that becomes a real challenge using these neuromodulatory modalities. On the other hand, they're non-invasive. And as I said earlier, one way you can make this pain worse is injure the nerve again. As long as these modalities are non-invasive, I have no problem with patients seeking or trying these opportunities because any pain reduction is helpful, no matter what source. And one briefly about deep brain stimulus, and that is in the neuromodulatory deep brain stimulation using implants have been advocated for decades. FDA recently reapproved the use of deep brain stimulus in intermittent pulse generations from the 1970s, and not a neurosurgeon. I don't do this. I know I'm aware of very talented neurosurgeons who apply this modality. Unfortunately, for facial pain, at least in my PTTNP patients, the Kaplan-Meier curve, although this isn't maybe a 20-year-old study, the long-term success rate is not very good. However, maybe the inappropriate diagnosis or rate. But deep brain stimulation should be in that neuromodulatory line of therapy when everything else is failing. So this is a treatment option. Now, finally, I want to wrap up on what are the treatment outcomes for PTTNP. This paper in 2004 under Muscle and Nerve was a very nice summary. Some of the things we just described were in treatment. And they wanted to point out several things that are important about these types of studies. There's a high placebo response. In fact, they recorded that 33 to 50% of patients with neuropathic pain have a placebo effect. The statistic changes using the best format for measuring pain has been the visual analog scale. And unfortunately, the visual analog scale is not necessarily a very reliable or stable or reliable value to compare individuals or conditions. So my use of the 0 to 10 scale may be very different than the next person's. That's the point. The active treatments for these studies are very short, 6 to 8 weeks, as you saw in that line 1 and line 2. So most of these studies were done on acute or subacute conditions. And the onset to effect often took days to weeks. So combining these two, the duration is unknown. I will give you some information in a little bit about that. And then the other problem is the off-label use. Neurontin is a good example. Gabapentin being off-label use for neuropathic pain, even though Lyrica is, but Neurontin is not. Now, this slide kind of gives you an idea of what works and what medications don't. And I use the term NNT, or the number needed to treat. And what that is, that's the number of exposures, treatment or days, however you want to define it, on the subjects the number of patients that need to be treated in order to have the impact on the one patient. These studies must have a placebo. And for neuropathic pain, any reduction of 50% or more in self-reported pain meets that criteria in the number of days. Anything less than 5 number needed to treat is a very good medication for this problem. And if you look at this chart over here, what you see is that that less than 5, you look at, here's the average and here's the range, that the antidepressant, tricyclic antidepressant, Elavil and Pamelor, actually are very effective using this criteria. So that's why they're in the first line. The SSRIs also, however, they're a borderline. But Betaxolene is also effective borderline. Neurontin is good, but you look at the range. So some patients is less than ideal or less than useful. Tegretol, very good, but again, look at the distribution. Dilantin actually did pretty darn good, but very few people use Dilantin because of the adverse events. Tramadol, pretty good. Again, but the problem is short duration, and in some patients, it's maybe ineffective. Then you have the narcotics. Here's capsaicin. Then you have the failures, basically, in my opinion, and that mexiletine, which is used for migraines, lidocaine variant for oral, or levodopa, again, and dextromethorphan. Remarkably does well because of the NMDA receptor agonist. So basically, these values define why that first and second line medications are justified. But this is important. And this study I want to present in 2015. It looked at the long-term outcome of the management of chronic neuropathic pain, a prospective observational study. And the primary outcome, at least 30% reduction in average pain intensity and 1 point reduction in interference of scale score or of brief pain inventory at 12 months, 1 year. So remember, all those studies I showed in the last slide were pretty much only 2 or 3 month follow-up outcomes. This is a 1 year. So we're looking at what are the benefits of these medications and medications for neuropathic pain. Unfortunately, the news is not good. Only less than 25% of patients met that criteria. The average BPI or brief pain inventory improvement was 1. And 92% of those patients taking these medications had at least one adverse event, and 43% had at least one serious adverse event, which is a significant concern for long-term management with these medications or therapies for PTNP. The bottom line is the evidence-based treatment of chronic neuropathic pain provides long-term benefits in only about a quarter of the patients seen at this tertiary care centers. And opioid therapy appear not to be beneficial. So unfortunately, the medical management for neuropathic pain is disappointing, and in the majority of patients, a large majority. Now, for post-traumatic trigeminal neuropathic pain, my colleagues, and again in Belgium and in London, published a very nice study, this specifically of trigeminal neuralgia, and you see the same pattern over long periods of time. Over this is 1 year, 2 years, sorry, for the up to 3 years. The patients whose symptoms recurred or returned when treatment, no matter how they were treated, with medications, with topicals, with surgical, the overall only 11% or 12% of patients had long-term benefits. And if you look at the variations in any of the treatments, there was really no significant difference. So they stated that the presence of any treatment did not have a significant correlation with persistence. After 20 weeks, the benefits of treatment are minimal. That's a disappointing finding, but a reality we have to deal with. Now, I'm a surgeon, and I do peripheral nerve surgery. And in my area, I perform microsurgery for the lingual nerve, and the infraalveolar nerve, and the infraorbital nerve, those same 3 nerves we talked about earlier. And this is just to kind of show you, now, sorry for the blood and guts here, but this is surgery. This is an irreversible intervention. And does it play a role? It appears to. We're understanding this a little bit more. This is basically showing my approach to a lingual nerve injury here. That's a very bad looking lingual nerve. And this is a result of a wisdom tooth extraction. The procedures we perform are intraoral, nothing on the outside. We have these wonderful, horrible medieval type devices that are retentions, but they're very helpful. You have to have access. You have to prepare the nerve and repair it. And we use a variety of techniques where we can reconstruct the nerve using a same-day procedure, 90 minutes, go home the same day kind of procedure. And same for the infraalveolar nerve. The difference is the infraalveolar nerve lives in the bone. So we actually do everything intraoral. We have to remove the bone. And this is an example of an implant-induced injury. Here's the infraalveolar nerve on the left side on these nerve hooks. And here's where the implant, you can see that just the point of it right here. And you can see how scarification has occurred. But that obviously implant had a mechanical damage. And then the repair is completed. So these are doable procedures we've been doing for years with very good success with non-neuropathic pain patients. So remember I said earlier, can we make pain worse, neuropathic pain worse? Yes, and that is re-injure it. So does a very active surgical repair induce neuropathic pain? And we asked that question, and this is the result. If you look at this chart, this is the number of patients. This is the months after surgery. All patients had surgery. This is 1 year, and this is before surgery. And they said 3, 6, and 12 months. If you look at, and these were all groups of patients who had surgery at our institute, one institute, and this is the group of patients who had, these are the incidence of neuropathic pain, sorry. That's what this is, the number of patients who developed neuropathic pain. In the patients who had no pain before, none of them developed pain afterwards. In the patients who had neuropathic pain before surgery, the majority of the pain recurred. So it does appear that the absence of neuropathic pain, when you do surgery, it does not cause surgery, neuropathic pain. So we're still trying to define why. You certainly would consider a genetic as a possibility. So these patients have an inherent protection mechanism against neuropathic pain when the nerve is repaired. I don't know that answer, but it's highly suspicious. Okay, so we know that neuropathic pain appears to not be caused by surgical nerve repair when neuropathic pain is not present before, but nerve repair is effective in resolving neuropathic pain in only a small minority of patients when neuropathic pain is present before. So we wanted to look at that group of patients a little bit closer, and that's what this study did. And this, again, pain intensity ratings. Again, the visual analog scale, not perfect, but a good way of measuring pain. This is before surgery. This is 3, 6, and 12 months. The different groups is this is the blue of patients who had no pain or had pain before. They all had pain before. Here's their pain levels. And then no recurrence. So what happens in this patient population, surgery is performed 3 months later. Some patients had a little bit of pain, but it was gone at 6 months and did not recur. Then there's this group of patients, this is a group of patients who had complete recurrence. And this group of patients had reduced pain, but it came back and it was actually worse than the preoperative. Then there's in the middle group, and this is the patients with incomplete recurrence. In other words, they have their pain levels, 3 months, pain is still there, less, but it does come back, but not more than the initial pain. So there does appear to be a cohort of groups of patient responses. We didn't understand it until we started picking them apart with larger numbers. And that's what we wanted to ask. Does injury to surgery time affect the postoperative recurrence of PTTNP? And here's the bottom line. The answer is yes. These are 4 groups of patients, and we had 70 patients, and about 20 in each group, close to. And this is basically this slide, this picture shows the outcome. This is patients who had surgery within 3 months. The success rate of eliminating pain was 67%. Between 101 or 200 days, in other words, up to 6 months, eliminating pain with surgery in 60% of patients. After 6 months, but before a year, the success rate was 35%. After a year, 0%. So these are pretty strong numbers that if we start to take apart the patients who responded to surgical intervention when they have neuropathic pain, timing is everything, according to this study. But also another factor was the degree of pain intensity. Patients who had lower pain intensity by more than 1 VAS value had a better outcome than patients who had higher intense distressing type of pain before surgery. So these are 2 predictors, pain intensity and time to surgery. So this is my wrap-up slide. And then in our conclusions at this point, the post-traumatic trigeminal neuropathic pain is a difficult problem with a poor prognosis. We don't understand what the neuro mechanisms really are. It probably is neurochemical, but there may be other factors. Why do some patients respond to surgery and others don't? And why is timing a factor and someone's not? I don't know. So our consensus is lacking about which therapy and the time of therapy is best, but we're trying to gain knowledge of that. Patients with neuropathic pain have mixed responses to treatment and suffer many side effects. It appears that only a quarter of patients treated with these modalities, including especially the medications, have any long-term benefits, and it doesn't appear to cure it. And our current outcomes, therefore, our pharmacological outcomes are actually disappointing and lead to often patient and doctor frustration. Surgical may be the answer, but I'm very careful that term may, because surgery has consequences. But if the surgery is considered, earlier the better. And so we need to reevaluate and continue to explore the benefits of that intervention. And if in fact that's true, that earlier the better is, we better be prepared to respond appropriately to these problems. So it's not perfect yet. And our recommendations is to establish functional recovery, but we also have to teach coping strategies for these chronic problems. And maybe a combination of those treatment modalities will be the future real treatment for post-traumatic trigeminal neuropathy. So thank you very much for the attention, and I look forward to your questions, and I hope I don't say I went over, but I appreciate the opportunity and the honor, and hopefully in the years to come, we'll have more answers for you. Thank you. Give it back to you, Ms. Bumbeck.